Welcome to this Step 3 review on Pediatric Fever Management. This video is brought to you by Roadmap to Residency. Pediatric fever is one of the most testable topics on Step 3, and the questions almost always turn on a single number, which is the age of the child. Our goal today is not to reteach all of pediatrics. It is to show you how these question stems are built and how to attack them, so that the moment you read the age of a febrile infant, you already know what the workup should look like. Make sure you are also working through your question bank and a solid review resource alongside this video, because these patterns are best learned by doing many practice questions. Let us get started. Here is what we are going to cover today. First, we will learn to sort every febrile child by age, because on this exam, the age of the patient is the single most important clue for how aggressive the workup should be. We will walk through the age-based protocols for the neonate under 1 month, the young infant from 1 to 3 months, and the older infant and child over 3 months. We will cover antipyretic dosing, and we will pin down exactly when to order laboratory studies and imaging. Throughout, we will work real question stems and explain why each answer choice is correct or incorrect. Remember, the medicine itself you should be learning from your question bank and a trusted pediatrics review resource. This video is about strategy so that you can apply that knowledge quickly and correctly on test day. Our first strategy is the most important one for this entire topic. Find the age of the child before you do anything else. A febrile infant who is under 1 month old, an infant between 1 and 3 months, and a child older than 3 months each fall into a completely different protocol, so the age is the hinge that the whole question turns on. Once you have the age locked in, read the last line of the question to see what is actually being asked, whether it is the next best step, the most appropriate test, or the best initial treatment. Then go back through the stem hunting only for the details that change management, such as the precise temperature, how well or how sick the infant appears, and whether the child has received vaccines recently. Train yourself to do this every single time. Strategy 2 is to remember that younger means a bigger workup. The younger the febrile infant, the more aggressive the evaluation has to be, because a young infant cannot wall off infection and can look perfectly well while harboring a serious bacterial infection. This is why a well-appearing newborn with a fever still gets a full evaluation, and why you should be deeply suspicious of any answer choice that discharges a febrile neonate just because the baby looks comfortable. The flip side is learning to spot the toxic-appearing infant. When the stem describes lethargy, poor feeding, a weak cry, mottled skin, or abnormal vital signs, that child needs urgent, broad evaluation and treatment regardless of age. When you see that picture, watchful waiting at home is almost never the answer. Here are the 3 age-based protocols, and these are worth memorizing cold. Under 1 month, a fever, defined as a temperature of 100.4 degrees Fahrenheit or 38 degrees Celsius or higher, always earns the full evaluation. That is blood, urine, and spinal fluid studies, admission, and empiric antibiotics while the cultures cook. There is no well-appearing exception for the neonate. From 1 to 3 months, the well-appearing infant is risk stratified using blood and urine studies along with inflammatory markers. Low-risk infants with reassuring numbers may be spared the spinal tap and watched closely, while any high-risk or ill-appearing infant gets the complete workup and admission. Over 3 months, a well-appearing and fully immunized child is worked up by hunting for a source, and the urine study is your highest yield test, especially in young girls and uncircumcised boys. Broad testing is reserved for the child who looks ill or is not immunized. Let us work through our first practice question. A 3-week-old infant is brought in for a temperature of 100.6 degrees Fahrenheit, measured at home and confirmed in the office. The baby was born at term, is feeding well, and looks comfortable, with normal vital signs apart from the fever, and there is no obvious source on examination. The question asks for the most appropriate next step. Notice the single most important fact in this stem, which is the age. This is a neonate under 1 month with a true fever. Read the 4 options carefully and lock in your answer, and then we will walk through the reasoning together on the next slide. Let us break this down step by step. First, spot the pattern. The patient is 3 weeks old with a confirmed fever, and the stem deliberately reassures you that the baby feeds well and looks comfortable. In a neonate, that comfortable appearance does not lower the risk because a newborn can look completely well while harboring a serious bacterial infection. Second, apply the rule. The febrile neonate under 1 month gets the full evaluation every single time, which means blood, urine, and spinal fluid studies, admission to the hospital, and empiric antibiotics while the cultures are pending. That is choice B. Third, eliminate the wrong answers. Reassurance with next day follow-up could miss a serious infection. A urine study alone or an oral antibiotic managed at home both skip the spinal fluid evaluation and the admission that this age group requires. The correct answer is to obtain blood, urine, and spinal fluid studies, admit and start empiric antibiotics. Notice how finding the age first pointed you straight to the answer. Here is our second practice question, and this one tests the middle age band. A 2-month-old, fully vaccinated, former-term infant comes in with a temperature of 100.9 degrees Fahrenheit. The infant feeds normally, is consolable, and looks well, with normal vital signs apart from the fever, and there is no clear source on examination. The question asks for the most appropriate next step. Notice the age, which is 2 months, placing this infant in the 1 to 3 month band where we risk stratify rather than automatically doing everything or nothing. Choose your answer and we will reason through it together. Let us work through this answer. First, place the age in a band. The infant is 2 months old, which puts the child squarely in the 1 to 3 month risk stratification group. The stem tells you the infant is well appearing and fully vaccinated. And those two features are exactly what allow a measured approach instead of an automatic full septic workup or an automatic discharge. Now, why does risk stratification win? The correct first step is to obtain blood and urine studies with inflammatory markers to risk stratify the infant, which is choice B. Discharging with no testing at all is too little for this age group. Ordering a chest scan and a head scan is the imaging overkill trap, with nothing in the stem to justify them. Starting empiric oral antibiotics with no testing treats the infant blindly and skips the information you need. The correct answer is to obtain blood and urine studies with inflammatory markers. Let us talk about antipyretic dosing, because the exam likes to test the comfort principle and a few safety traps. The key idea is that we give antipyretics for the comfort of the child, not to force the thermometer back to normal. So the right answer treats the child who is distressed or uncomfortable, and not simply a high number on the chart. Acetaminophen is the agent that is safe across all ages, including young infants, and it is dosed by weight at roughly 10 to 15 milligrams per kilogram every 4 to 6 hours. Ibuprofen is reserved for infants older than 6 months and is dosed at about 10 milligrams per kilogram every 6 to 8 hours, and you avoid it when there is dehydration or a kidney concern. 2 classic wrong answers show up again and again. The first is aspirin, which we avoid in children because of the risk of liver and brain injury. The second is reaching for combined or alternating agents as the very first move, which mostly adds the chance of a dosing error without a clear benefit. Here is our third practice question, and it brings together the older child protocol and antipyretic dosing. A 2-year-old, fully immunized child has had a temperature up to 102 degrees Fahrenheit for 1 day, along with a runny nose and a mild cough. The child is playful, drinking well, and well-appearing, with clear lungs and normal vital signs apart from the fever. The parents are anxious and want to know what to do. Notice the age, which is over 3 months, and notice that the child is fully immunized and looks well, with an apparent viral source. Pick your answer, and we will reason through it on the next slide. Let us break down this answer. First, read the reassuring signs. This child is over 3 months old, is fully immunized, and is well-appearing, with a runny nose and a mild cough that point to a simple viral upper respiratory infection. That exact combination, an older, immunized, well-appearing child with an apparent viral source, is the low-risk picture that calls for supportive care rather than an aggressive evaluation. So the principle here is comfort over overkill. The correct answer is weight-based acetaminophen for comfort, along with supportive care and clear return precautions, which is choice A. Now eliminate the rest. A full blood, urine, and spinal fluid workup with admission is overkill in a well-appearing, immunized toddler with an obvious viral cause. Aspirin is contraindicated in children because of the risk of liver and brain injury. A chest film and broad-spectrum antibiotics chase a bacterial source that simply is not there. Each wrong choice either over-tests or over-treats. The answer is comfort-focused supportive care with return precautions. Here is a critical exam day pearl that ties this whole topic together. The fastest and most reliable way through any pediatric fever question is to anchor on the age before you even look at the answer choices. Under 1 month means the full evaluation with admission and empiric antibiotics. 1 to 3 months means risk stratify the well-appearing infant. Over 3 months means hunt for a source in the immunized, well-appearing child. Let that single number set your expectation for what the workup should be. Then check 2 modifiers that can override the age-based default. The first is appearance, because a toxic or ill-appearing infant earns a broad, urgent evaluation at any age. The second is immunization status, because an unimmunized child is handled more cautiously. When the age, the appearance, and the vaccine history all line up, the correct answer usually jumps off the page. That wraps up our review of pediatric fever management strategy. Remember the core habit, which is to find the age first and let it set the workup, then adjust for how the child looks and whether the child is immunized. Keep drilling febrile infant questions in your question bank and learn the underlying medicine from a trusted pediatrics review resource, because these patterns become second nature through repetition. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized plan. If this video helped you, please like and subscribe for more board review content. Good luck on your exam, and we will see you in the next one.